Welcome. Serum testosterone improves the accuracy of the prostate health index for the detection of prostate cancer. Over to you.
Yes, thank you. Good morning, everybody. I will try to make it very short and easy. I have only 10 slides. So the aim was that we see already some biomarkers which are FDA approved. That's PCA3. That's a prostate health index. I call it Phi because it's the original Greek pronunciation and the German one. I don't use the English one. And we all know that testosterone, we also have total, free, and bioavailable testosterone and the sex hormone binding globulin. They were also, in some studies, tell as a potential prostate cancer biomarker. And we put this together, and we know that the long-established assumption that prostate cancer is testosterone triggered, this is obviously wrong. So we take almost 200 samples with an equal distribution of prostate cancer and BPH. All were biopsied and all had a PSA below 20, and the blood sampling was between 2009 and 2012 and between 8 and 11 in the morning because of the testosterone. We measured PSA, free PSA, and the -2 pro PSA and all the testosterone derivatives. And we calculated also the free and bioavailable testosterone according to one formula. You can use this with a given albumin concentration of 43 gram per liters, but we used our own measured albumin, which was somewhat lower, but there was no difference in between. You see here the first results, the distribution. You see the typical behavior. PSA was somewhat differentiating % free PSA, and you see Phi here. It's well differentiating 60 versus 36, and some testosterone derivatives are not really improving here, and also the bioavailable testosterone, they're not discriminating. But the most important thing are the areas under the curves. If you see here, PSA, % free PSA, it's 0.65, so it's really not good. Testosterone is bad. And total testosterone the same. The only marker which was really good was Phi. It had 0.73, and the best model we used with Phi and bioavailable testosterone only improved this marginally to 0.76. Well, these are the RC curves again to have a view on it. You see again the pink curve is Phi, and the rest is not really good discriminating. And when we thought, okay, that's it, you cannot really improve something, and then we made a discrimination, the testosterone level of 8, so normal testosterone, and below it would be hypogonadism. And you see in the normal range, Phi is still 0.7, so it's not really good. These are almost 150 patients, but if you now look at this slide, of course, we only had 42 patients, but in those patients with a low testosterone, Phi is dramatically increasing from 0.7 to 0.84. Yeah, it's really good discriminator. And as we compared this between the men with normal testosterone value, this was significantly better. So we also checked some correlations. So total testosterone correlated with all parameters, but not with Phi or prostate volume. The Phi itself correlated, of course, with total PSA, with the Gleason, which is good because PCA3 does not correlate with Gleason, and a little bit inverse with prostate volume. And the Gleason, of course, correlated with PSA, but also with no other parameters. And the primary Gleason, only the primary, was weakly correlated negatively with total testosterone. You see here the distribution of the prostate cancer patient, these 100 patients. And we found even that in prostate cancer with a low testosterone, they had more aggressive Gleason scores, 7 and more, in comparison to the patients with normal testosterone levels. So almost 70% versus a little bit more than 40%. So this is also already available, this article, since a couple of days ago. We published in Clinical Biochemistry, you can see it here. And I will already summarize. Phi was the best parameter, 0.73, and all testosterone values and also SHBG were less powerful, and the addition of bioavailable testosterone or total testosterone to our logistic regression model yielded only in a small area under the curve increase. But we found that in hypogonadism patients with a low testosterone, below 8, the area under the curve for Phi increased from 0.7 to 0.84, and we might later considerate the testosterone that it still improves Phi. So before I say thank you, I will also show the last slide for Maciej, my friend. This is Germany, but to make this picture, I had to step on a hill in Poland, because this is a border over Oder, and this is one of the largest national parks in Germany. So we also have nice areas in the northeast of Germany. Thank you very much.
Thank you.
It looks like a picture of most of England at the moment. Yeah.
Yeah, that's okay.
Great. Any questions? Lawrence,
Professor Uller, yeah.
at the back, and then a microphone at the front. So, 1, 2, 3. So, yeah.
So the observation that low testosterone is associated with worse prostate cancer is quite controversial, and kind of has been a topic of debate for a long time. One obvious association is age. You assume that the patients with the low testosterone on average were considerably older, and I don't know if I didn't hear you address that point, and of course they would be expected to have higher grade prostate cancer. So I assume that your analysis showed that age was not an independent predictor.
I just see it. Yeah, age should nothing. We can check it. We only had a small number of patients. Yeah, we will recheck it, another 400 patients, and then we can see it if it's really rated to age only. But I don't think so. There might be another relationship between free testosterone or testosterone and the free form of PSA. We don't know so far. No.
Laurie, I hate you. I was going to ask the same question.
Okay, that's fine. Yeah.
No, from the
We can only speculate. Yeah.
From the ICGC study, we have the impression, it's just a thesis, that we have two types of prostate carcinoma in terms of pathogenesis. And this is a younger one with more temporous ERK fusion, more influenced by testosterone, and the older ones who have more mutations and alterations in the genome. So I was wondering also if there is a difference in respect to testosterone and its influence in the different age groups, but you showed it's obvious not the case.
I don't think, The number of patients, again, it's too small, to really make a correlation to this.
Yes.
Yeah. Peter Albertson.
Question.
Just so I'm clear, you developed your characteristics for Phi on this test, and then you, in other words, was there an independent population that you tested these parameters on, or is it the same?
No, that's Phi. We checked in other cohorts again, already. We did a multi-center study in more than 1,200 patients,
So this is now an independent sample that you're using Phi that was previously developed. That's one to make sure about.
And we want to recheck it again in another 400, 500 patients, also from other clinics. So, because you need to make sure that the testosterone is correctly taken. If you take it from another clinic and they don't really make the blood draw in the morning, so you cannot rely on these samples.
Okay, no more questions? Yeah.
Maybe a last question. Would you advise differently people with low testosterone and high testosterone to go to active surveillance protocol, or?
Oh, this is a completely different topic. We can check active surveillance. You can also use Phi in active surveillance. You can use the MRI, which we will also increasingly do. I would not rely on the testosterone on active surveillance. I think this is too early.
Okay.
I would more rely on the MRI in this one.
Thank you. Great.
Very nice.
Thank you very much.
Thank you.